I'm Janice Jew. I'm a transplant hepatologist at OHSU in Portland, Oregon. And to my right is our AASLD president, probably needs no introduction, Grace Sue, from the University of Michigan. I just want to go over a little bit of our format this morning. We're going to start with a keynotes talk, and our Dr. Sue will introduce our speaker in just one moment. That's going to be followed by abstracts, 4 abstracts, 15 minutes each, and we will be taking questions within that 15-minute period. So I'm just going to hand things over to Dr. Sue to introduce our speaker today.
Great. Good morning, everyone. Thank you for being here so early in the morning. We're so glad to see you. Today, we're so delighted to have Dr. Kaplan give us a talk on a very important topic, which is our paradigm shifts in the care of portal hypertension. Dr. Kaplan is a professor of medicine and director of hepatology at the Perelman School of Medicine at the University of Pennsylvania. He's also a GI staff physician and director of hepatology at the Corbel Michael J. Crescens VA Medical Center in Philadelphia. He is currently engaged both in epidemiological, translational, and prospective trials. Relevant to his presentation, he is the national co-PI on the SACRED study. It's a VA merit-funded prospective clinical trial on the impact of statins in the natural history of portal hypertension. He has held multiple committee leadership roles in AASLD, and he recently co-chaired and wrote the AASLD practice guidance related to portal hypertension and management of varices. So we're very delighted to welcome here for our keynote speech. Thank you.
Well, thank you, Grace, and welcome everybody. I was going to say, everybody, we all know each other. Move forward. And thank you, Grace and Janice, and for the committee for selecting me to present today. And I do apologize in advance. I wrote this more for an AGA audience, and with the expertise in the room, this may be a little bit too basic, but I hope that there's something in it for everybody. And we'll get started. So, oh, here. It's not, sorry. Yeah, I did that. Okay, now it's working. Perfect, thank you. I'm arrow incompetent today. All right, so these are my disclosures. So the objectives of today's talk are to try to explain why we should all care about portal hypertension, how to identify clinically significant portal hypertension both invasively and non-invasively, and focus on prevention and preemption. Prevention of portal hypertension in the first place and preempting complications once portal hypertension is present, and some look at the future in terms of what new treatments may be coming out to address portal hypertension. So I think it's always important to go back to the basics to give everyone for level setting about the pathophysiology of portal hypertension as we know it. And it starts with liver cell injury, a mild injury that leads to portal fibrosis. This leads to sinusoidal changes that I'm going to go over in a little bit more detail, resulting in compensatory cardiovascular and renal changes, ultimately the development of ascites, the development of varices, and ultimately variceal hemorrhage. And this really starts at the level of the sinusoid in all cases, and the mechanism of injury can vary across diseases, but there's some type of injury to hepatocytes that leads to the activation of DAMPs, release of various cytokines that activate non-parenchymal cells in the liver environment, including direct activation of hepatic stellate cells, Kupffer cells, and liver sinusoidal endothelial cells. And then these cells themselves also have other factors. Kupffer cells directly activate hepatic stellate cells to activate and execute their program. Liver sinusoidal endothelial cells become procoagulant. They upregulate various factors that may lead to local thrombosis. There's an imbalance of von Willebrand factor and anti-clotting proteins in the liver sinusoidal endothelium that leads to microthrombosis. And the release of platelet-derived products further activates hepatic stellate cells. These activated hepatic stellate cells proliferate, they differentiate, they start laying down type 1 collagen and become contractile and cause distortion of the flow of blood through the sinusoids. And that's the first step. And that distortion of the sinusoids contributes to about 70% of the increased pressure in the sinusoids related to progressive fibrosis. But these changes also have other effects on the non-parenchymal cells. I'll focus on the liver sinusoidal endothelial cells. These cells line the sinusoid themselves, and they become altered. They lose their fenestrations. Typically, they allow fairly large macromolecules to pass through pores to directly reach hepatocytes. These become smaller, and these cells that normally can vasodilate upon mediation with various signals, including meals, lose the ability to vasodilate. And that loss of vasodilatory capacity and baseline vasoconstriction within the sinusoids contributes to about 30% of portal hypertension. So what does this then lead to? So this increase in resistance of flow in the sinusoids leads to some downstream changes throughout the body. And as a result of resistance to flow within the sinusoids, there's a compensatory increase of flow into the splanchnic organs in order to try to overcome this resistance. And this process is actually relatively poorly understood, but it's thought to be mediated by the production of various vasodilatory mediators such as nitric oxide, hydrogen sulfide, glucagon, among others. And the splanchnic vessels also become resistant to vasoconstriction, and there's a dilation of arterioles into splanchnic organs, leading to increased flow into these organs to try to overcome that resistance. But that increase of flow within the splanchnic circulation leads to an increased capacitance in the splanchnic circulation, leads to underfilling of the systemic circulation, which we term decreased effective arterial blood volume. And this decrease in blood flow to other organs, the adrenal glands and kidney, I guess the brain shown in this picture, leads to a decrease in systemic vascular resistance. And to overcome that, there are cardiac changes that occur, increase in cardiac output, activation of the renin-angiotensin system and AVP, increase in sympathetic tone to try to increase flow to those organs. Ultimately, this leads to afferent vasoconstriction of the renal arteries, leading to sodium retention and fluid retention that can contribute to ascites and hepatorenal syndrome. In order to decompress the system, there is a natural formation of collaterals that lead to the generation of varices. And this is not that complex of a process. There's existing collaterals, obviously, between the stomach and esophagus that are prone to dilate around stomas and other organs in the retroperitoneum. And there's also a VEGF-mediated neovascularization that facilitates this process. Now, during this increase in pressure, we tend to focus on varices when we talk about portal hypertension, but ascites is the other major complication. And how we're thinking about how ascites develops and the pathophysiology is beginning to evolve a little bit in the field. And this is some work highlighting some work from Yasuko Iwakuri at Yale and others, Michael Thies, Becky Wells. We're beginning to appreciate more that the lymphatic system in the liver is actually really highly important, and that we really can think of sinusoids as the filling vessels for lymphatics. Lymphatic vessels run, we don't see them on H&E, we largely ignore them, but they're present throughout the liver, and they collect in two areas, primarily in the portal area as well in the subcapsular area. And when there's increased hydrostatic pressure within the sinusoids as a result of portal hypertension, that drives an increase of lymphatic fluid, and that needs to be collected by these lymphatics and again go through the cisterna chyli, through the thoracic duct back to the circulation. And it is really now thought that the reason that ascites develops is that this increase in hydrostatic pressure and increased lymphatic production leads to leakage of fluid outside the liver called the weeping liver. And this was actually observed 20, 30 years ago, maybe before longer, in surgical series and somewhat been sort of ignored over time. But the weeping liver generates the production of ascites, and you develop ascites clinically when the hepatic leakage rate overwhelms the peritoneal lymphatic absorption rate. And ascites has low albumin for probably two reasons. It's not actually well understood, but there's the capillarization of the liver sinusoidal endothelial cells leads to reduced filtration of albumin into the fluid. But lymphatic vessels also have active reuptake of albumin. And so it's probably a combination of those two factors. So getting back to varices, the collaterals form to decompress the vessels. Why do varices bleed? And this has to do with physics. My son is going into physics. I've been thinking about physics a lot lately. He's going to Michigan next year. I'm so excited. Why do varices bleed? Varices bleed due to pressure, not due to trauma. And this is an important thing that we clinically always have to explain to our house staff, why you can place an NG tube in these patients. You can do a transesophageal echo in these patients. It's not trauma that causes bleeding. It's pressure. So how does pressure generate in varices? Pressure is, according to Ohm's law, related to flow and resistance. So we've talked about the resistance due to scar. We've talked about the resistance due to dynamic changes in the endothelium within the liver. And there's also increased flow due to splanchnic vasodilation. So we have increased pressure. And varices bleed in the esophagus when the transmural pressure overwhelms the ability of the wall to contain that pressure. And that's related to the radius of the varix. The larger the varix, the more thin the wall is and the greater the transmural pressure. And so large varices are more likely to bleed due to that pressure. And this picture that I show on the bottom right here, I actually pull up on Dr. Google all the time in clinic and show patients when I'm explaining what is a varix and why do we band them. I actually find this picture to be really particularly helpful to explain, that banding the varices doesn't obliterate collateral flow. It just obliterates the collateral flow within the lumen that could cause bleeding and problems. So why do we care about this in terms of the natural history of cirrhosis? So this is work going back now nearly 20 years from Gennaro D'Amico and Guadalupe Garcia-Sao, explaining the natural history of cirrhosis in the context of ascites and varices. So most patients are compensated and do not have varices or ascites, and those patients are at low risk of death. But once patients develop a certain level of pressure, and that pressure is 10 millimeters of mercury of pressure within the portal system, they can develop varices, and that's the minimum pressure required to develop ascites. And once patients meet this threshold, which we call clinically significant portal hypertension, the risk of death or decompensation is up to 10% per year. And so what we now call this clinically in our new nomenclature is that patients who have compensated advanced chronic liver disease, but the pressure is less than 10, they do not have clinically significant portal hypertension, but patients who have compensated advanced chronic liver disease with a portal pressure greater than 10, that we're going to call in the clinic clinically cackled with clinically significant portal hypertension. And then ultimately, once patients obviously develop decompensation, the natural history worsens significantly. Once patients develop ascites, there's a 20% annual risk of death. And if you have bleeding and ascites, the mortality rate is nearly 60%. And where does this number 10 come from? So this is old data from the timolol trial showing that patients who had a HVPG greater than 10 had a worse prognosis than patients who had HVPG less than 10. And among the patients with an HVPG greater than or equal to 10, as you can see, there's about a 10% annual risk of death or clinical decompensation in those patients. And this has been borne out in repeated observational studies over time. So how do we identify clinically significant portal hypertension? And because it's an important milestone in the natural history of cirrhosis. We can do that directly through hepatic vein wedge pressure measurement. Actually rarely done, but if it's greater than 10, that identifies CSPH. The presence of any varices on endoscopy tells you that the patient most likely has an HVPG greater than 10. You must have an HVPG of 10 in order to develop varices. Also, if there's portal hypertensive gastropathy, that's a sign that the patient has clinically significant portal hypertension. It can also be done on cross-sectional imaging. If a patient has visible varices on a CT scan, MRI, or hepatofugal flow on a Doppler ultrasound, these are signs of clinically significant portal hypertension that we can use. More and more, though, we're using non-invasive liver diagnostic assessments, or NILDAs. And the rationale for this goes back to a lot of work from Juan Abraldez and others looking at the correlation of non-invasive markers with portal hypertension by HVPG. When I'm showing in this tiny figure on the upper left here is that there's a nearly linear association of HVPG, FibroScan elastography stiffness scores and measured HVPG. Caps out around 20, and then it flattens out. And similarly, as platelet count goes down, that's relatively linearly associated with HVPG. And if you take these two markers together as a predictor, you have extremely high discriminatory capacity, AUC of 0.85 for identifying individuals with an HVPG of greater than 10. And it's not only highly discriminatory, it's very well calibrated when you validate this prospectively. And it works across multiple diseases. There's a few diseases where it doesn't work so well, but it works really well in alcohol-related liver disease, hepatitis C, hepatitis B, not so much, usually due to the inflammatory state that's present there, and most patients with AASLD. So we can use this to come up with a fairly simple paradigm. We can use these numbers first to rule out clinically significant portal hypertension. So if a patient has a liver stiffness measurement that's less than or equal to 15 kilopascals and a platelet count greater than 150, the likelihood that that patient has clinically significant portal hypertension is less than 5%, and we can rule out clinically significant portal hypertension at that point in time. Similarly, if these numbers are on the other extreme, if the liver stiffness is greater than 25 kilopascals in most patients, or it's between 20 and 25 kilopascals and the platelet count is less than 150, or it's between 15 and 20 kilopascals and the platelet count is less than 110, your positive predictive value for clinically significant portal hypertension is in the 60 to 80% range. And then there's going to be some patients in the gray zone. But this is a fairly simple to implement approach to risk stratify patients in the clinic. And this has been codified in the AASLD NILDA guideline, that came out earlier this year. Rich Sterling was the lead author on that, and nice little, very simple, straightforward figure. In the portal hypertension guidance that came out at the end of last year, we have a more complicated graphic that I would refer you to. I only bring it up here. It essentially mirrors that of the other guidance statement. But we also put in this, we appreciate that not everyone has access to FibroScan. The cutoffs for identifying clinically significant portal hypertension with non-FibroScan transient elastography or MR elastography is not as well validated, but we're beginning to get some cut points that may be useful in the clinic, and I would refer you to that. And the enhanced liver fibrosis score can also potentially be used for risk stratification. So I'm not going to go into details here, but please refer to the guidance document for some guidance. So we've identified that we can identify clinically significant portal hypertension, and really we want to intervene. And so what can we do to prevent the progression of patients to develop large varices or varices that may bleed? And it's important to remember that every time a patient bleeds from varices, even with our modern approaches, there's still 20% mortality associated with that. So we really want to do our best to prevent that first event. So the simple things: treat the underlying etiology, get the patient on appropriate antiviral therapy for their virus, Hep B or C, reduce or eliminate alcohol. Can't overstate the importance of that for patients with AASLD and MASH, weight loss. But really the main intervention pharmacologically beyond these more simple lifestyle and etiology-specific interventions is non-selective beta blockers. And that really is where the paradigm shift starts to begin. And this comes primarily from the Pradeshi study. Most people have heard of this study so far, but I'm just going to review it very quickly. It was a multi-center study done in Europe where 201 patients these are patients who did not have large varices. They either had no varices or small varices, but on an HVPG, they had a pressure greater than 10. And it's a bit complicated how they randomized the patients, but essentially at the end of the day, the patients were randomized to either a non-selective beta blocker or a placebo and followed over time. And they were followed for a composite outcome of variceal hemorrhage, ascites, encephalopathy, or death. And the primary outcome is shown here on the right. And what you can see is that after 2 years of treatment, the curves diverge, and that met clinically, the hazard ratio is about 0.5. And the main effect of non-selective beta blockers wasn't the prevention of varices or variceal bleeding. The main effect was a reduction in the development of ascites, and that's a key point. The effect was greater in people who did have small varices rather than no varices. In this study, it was a mixture of hepatitis C pretreatment, alcohol. When they did subgroup analysis, there was no effect seen in the alcohol-related liver disease patients. But these subgroup analyses are always challenging, and it's pending validation in another prospective study, but there's been quite a bit of other validation done. Candide Villanueva did a individual patient meta-analysis of this study plus 3 other studies, reproduced the statistical significance of the effect. We did some work in the VA. My colleague Marina Serp or Nadim Mahmood did a new patient analysis looking at patients who would have been candidates for the Pradeshi study and were either, in that setting, were either started for high blood pressure on a selective beta blocker versus a non-selective beta blocker. And while it didn't quite meet statistical significance, almost exactly reproduced the curves of Pradeshi in terms of reduction in the risk of decompensation over time. And then just last month, really nice work from a European group showed in a large retrospective study, again, reproducing evidence of the benefit of non-selective beta blockers of preventing either liver-related decompensation or death during follow-up. And this was present in people with or without varices. So I think we have while we don't have 2 prospective randomized control trials, we're I think, close enough in terms of the evidence to really recommend this as an approach. And so this changes how we would recommend managing the patient with clinically significant portal hypertension. We can identify the patients who are at risk of bleeding and decompensation, either invasively or non-invasively. We know that non-selective beta blockers can prevent a first bleeding episode in primary prophylaxis trials, but they also prevent ascites. And so in the past, where we would screen patients that were at least risk by the Baveno 6 criteria for varices and then either randomize them or select them for either beta blockade or banding, we recommend now that if you identify that patient, you start them on a non-selective beta blocker. And the reason is not only to reduce their risk of initial bleeding, but also to reduce their risk of developing ascites and further decompensation. And there still will be endoscopies and band ligation that needs to be done. Every time I present this, people complain, well, our trainees will never do these interventions. There are many patients who can't tolerate non-selective beta blockers or have contraindications for which the old paradigm would still be recommended. So again, just reminding everyone of some of the randomized prospective controlled trials showing that carvedilol is superior to band ligation in primary prophylaxis of varices. So this, again, if you saw a patient with varices, RCT data suggests that carvedilol is a better intervention than banding in most cases. And in secondary prophylaxis, we have more and more data showing this, some data from the German group, actually Austrian group, and Italian group, showing that in retrospective data, the effect of carvedilol is greater than propranolol in terms of preventing initial decompensation. Why is carvedilol better than propranolol? There's a higher HVPG response. If you actually give patients carvedilol during an HVPG, they're more likely to reduce their portal pressure to target. And in observational studies, there's less variceal rebleeding, there's less non-bleeding further decompensation, and lower liver-related mortality. So we recommend that for patients with clinically significant portal hypertension, that they be started on a non-selective beta blocker. We recommend starting with carvedilol 6.25 milligrams daily. It can be increased to 6.25 milligrams twice daily after 3 days. That's hard for me to do in my clinic, but theoretically. The target is 12.5 milligrams per day. In the Pradeshi study, the median dose was actually about 18 milligrams per day. So if you can go up a little bit higher, it may be beneficial, but 12.5 milligrams per day actually seems to be where the effect plateaus. It actually, because of long reduced metabolism of carvedilol, the half-life is much longer in patients with cirrhosis, and so you can actually give it once daily, and it has a similar AUC. There's no heart rate goal with carvedilol. You're not titrating to a heart rate. You just want to make sure the patient's systolic blood pressure is more than 90 and they're not dizzy when they stand up. The adverse events associated with it are similar for all beta blockers, and you treat them indefinitely until they get a TIPS or transplant. And while they're on a non-selective beta blocker, there is no indication for screening endoscopy. So just to summarize, clinically significant portal hypertension can be non-invasively identified by stiffness, liver stiffness, and platelet count. If we put patients on carvedilol, we can reduce the risk of decompensation and bleeding, and that obviates the need for screening endoscopy. Carvedilol is preferred because it's more effective than other non-selective beta blockers. And again, screening endoscopy is not necessary in compensated or decompensated patients who have not bled while on a non-selective beta blocker. So there have been concerns about the use of non-selective beta blockers in patients who have refractory ascites based on some equivocal data from the past. And at this point, more data support that there is safety and benefit in patients with ascites than studies that suggest that there's a harm. But again, you want to keep the systolic blood pressure greater than 90 because below that, renal perfusion suffers. So what else can be done to prevent progression? Statins. What about statins? And we're very excited about this. Why are statins thought to be beneficial? It's not because of cholesterol lowering effect. It's because of the vasodilatory effect that statins have within the liver, and hope that this reduces systemic intrasinusoidal resistance and reduces portal pressure over time. Statins have multiple other pleiotropic beneficial effects that I won't go into detail about. So where are we? And I apologize, it's a bit of an ugly slide, but there have been several studies that have been completed recently, and so far the news has not been great. But I want to caveat that these have all been very small and generally short-term studies. And go back to the Pradeshi study. It took 18 to 24 months before the benefit of non-selective beta blockers was evident in affecting the natural history of cirrhosis. And so I think these shorter studies we have to take with some grain of salt. But a recent Danish study, 78 patients exposed to statins for 6 months. It was very safe, but they didn't observe any changes in HVPG or clinical effect. Most people are familiar with the liver hope data. This was more decompensated patients who were treated with rifaximin and statins, and they didn't see any effect on ACLF death or the need for transplant. There's been a recently completed published study looking at the effect of HCC on AFPL3%, small study, 6 months, no change was observed. There was a larger study, methodologically really well done in India, where simvastatin was added for carvedilol. This study was for a year, and for 2 years. They did not observe a benefit of statins when added to carvedilol for reducing effects further than carvedilol. And there was a very small study out of Denmark called Stat Liver that, actually I already talked about that one. It's a really bad slide, I apologize. So ongoing, we have the Sacred study. Tamara and I are co-PIs on that. We finished enrollment, waiting for follow-up. We were ultimately able to enroll 142 patients, which was unfortunately well below our target, but we should have results first quarter 2026. The liver cirrhosis study is looking at rosuvastatin with a target enrollment of 256 patients. Larger study, longer study, and hopefully together we will be able to identify and address clinically whether or not statins have a benefit. And there's a study recruiting now between MGH and UT Southwestern looking at atorvastatin as a way of reducing the risk of liver cancer. So just have a couple minutes left here. I want to highlight two other approaches I think are really exciting. So This is a study from 2012 from Erika Via from Germany, looking at the role of enoxaparin in preventing decompensation. And it brings up the idea that if we can reduce microthrombosis within the liver, that we might be able to reduce the risk of decompensation. And this was a really, I think, well done study looking at 2 years of enoxaparin, and you can see that they were looking at portal vein thrombosis, but it also reduced decompensation and death when they gave patients with Child-Pugh B cirrhosis blood thinners. And so there's a DOAC study ongoing, multi-center study, 21 sites, called the AAPS study. That is expected to complete late this year. There's no preliminary data that I could find, but it's an exciting approach, and it's something that we could easily clinically apply. And there are a few other vasodilators that are now in prospective studies. There's a soluble guanylene cyclase inhibitor the idea here is directly dilate the portal vein and liver sinusoidal endothelial cell. 2 phase 2 trials ongoing, and a 5-hydroxytryptamine receptor 1 alpha agonist has 3 trials ongoing in China. So a lot of exciting work to try in this space. So to summarize, portal hypertension is a dynamic and potentially reversible process. HVVG of 10 is our marker of clinical significance. The non-invasive liver diagnostic tests are reasonably accurate for identifying this at the point of care. Non-selective beta blockers change the natural history. We aren't quite at 2 RCTs, but we're close to reaching level 1 significance. And statins, portal vasodilators, and anticoagulants remain investigatory but promising. And so the take-home is, at the point of care, it's time we start documenting in terms of tackled and clinically significant portal hypertension. I think this is now standard of care. We can identify this at the point of care. Consider strongly initiation of non-selective beta blockers rather than an EGD-based stratification strategy, and keep an eye out for new data in 2026. So, thank you.
Thanks, Dr. Kaplan, for that comprehensive and practical review. Our first abstract is a randomized controlled trial of hepatology specialty clinic-based stepped treatment to reduce unhealthy alcohol use in vulnerable patients with chronic liver disease. This will be presented by Vandana Khalili on behalf of the authors.
Thank you, Dr. Zhu, and Dr. Su, and the organizing committee for the opportunity to present to you our work today. These are my disclosures. None is relevant to the content of the presentation today. Unhealthy alcohol use is common in chronic liver disease, and alcohol-associated liver disease is also highly prevalent, currently representing the most common indication for liver transplantation and high rates of liver-related mortality in this country. Routine alcohol screening and referral to integrated evidence-based alcohol use disorder treatment programs is therefore recommended, and this includes behavioral and pharmacological therapy, but many hepatology practices, however, lack structured in multidisciplinary programs to address AUD. Step care models that increase or step up intervention components based on initial response to treatment are effective in managing chronic diseases, and integrated step care alcohol treatment models tailoring treatment to patient response has been implemented in other settings, including HIV care, but has been shown to increase uptake of alcohol use within the setting of alcohol use disorder. In this study, using a randomized controlled design, we assessed the effectiveness of a stepped care model compared to usual care in reducing alcohol use among patients with chronic liver disease in hepatology clinics across 3 healthcare systems. Patients were enrolled with chronic liver disease and unhealthy alcohol use at the San Francisco Safety Net and San Francisco and Palo Alto Veteran Affairs healthcare systems. Adults with a diagnosis of chronic liver disease with access to a telephone or a digital device and had reported more than moderate alcohol use or had binge drinking within the prior 30 days, defined as more than 7 drinks per week or 4 or more drinks on any given day if women, and more than 14 drinks per week or 5 or more drinks on any given day if men were included. Those with received alcohol treatment in the prior 30 days, women who were pregnant or breastfeeding, those with languages other than English, Spanish, and Chinese, and those unwilling or unable to participate in the study were excluded. Those eligible to participate underwent the following measures at baseline: social demographic questionnaire, adult use disorders identification test or audit, timeline follow-back for current alcohol use, measures of anxiety and depression and liver disease-related quality of life, as well as measures of importance and confidence to decrease alcohol use. Liver disease etiology, severity, and adverse outcomes were extracted from electronic medical records. Participants were then randomized to the step care intervention, or SAT, versus usual care. Those who were randomized to usual care received a pamphlet and written information about adverse effect of alcohol use, as well as resources for alcohol treatment. The step care intervention group underwent 3 sessions of motivational interviewing by telehealth, 2 weeks apart, and the alcohol use were then assessed at 3 months of follow-up. Those who had more than moderate alcohol levels at 3-month time point when then stepped up to referral to addiction services with the management with pharmacotherapy as indicated. Patients could also step up at any time if they requested or if it was deemed that it was indicated for them to do so. After the intervention, the patients were then followed for another 6 months until month 12. The study measures were performed at 6 months and 12 months, and the outcomes to progression of cirrhosis, decompensation, hospitalization, and death were also captured on follow-up. Today, I'll be presenting the results of our 6-month data, which is the end of the intervention. Descriptive analysis for the study included comparison of intervention and control characteristics at baseline, 3 months and 6 months, as well as adverse outcomes. We used generalized linear mixed models for repeated measures to understand the associations of change in drinks per week over time with SAT or step care versus usual group. The participant flow is as follows. 157 patients were enrolled, 81 were randomized to the SAT, and 76 were randomized to usual care. By the end of the intervention at 6 months, 138 patients reached that time point. Overall, 40% of the patients were enrolled at the safety net healthcare system and 60% from the VA sites. The baseline characteristics of the SAT and control groups did not differ with respect to various parameters at baseline. The overall median age was 61. Majority were either white or Latino ethnicity. A quarter had less than high school education, and more than 50% had annual income of less than $30,000 per year. With respect to severity of liver disease, nearly half of the population had a diagnosis of cirrhosis, with 1/3 of them having prior or current decompensation of liver disease. The median male NA was 9, and the quality of life score was 79. Approximately 94% had an audit score of about 8, suggesting harmful or hazardous alcohol consumption. 26% and 30% respectively had probable generalized anxiety disorder or major depression on mental health measures. And overall measures of confidence and importance to discontinue alcohol use was high with a median score of 8. Following intervention, the proportion of the patients with at most moderate alcohol use or without binge drinking at 3 months and 6 months increased in each of the treatment arms, with the SAT represented as solid bars and control groups in hashed lines. And at 6-month time point, 24% in the intervention and 18% in the control groups were abstinent from alcohol use. This graph depicts the mean drinks per week in the prior 30 days by treatment arm at baseline, 3 and 6 months. The difference in the mean drinks per week between SAT and the control group at each time point was not significant. However, the SAT group had a significantly greater reduction in drinks per week from baseline compared to the usual care group at both 3 months and 6 months. Moreover, on multivariable analysis that included age, race, cirrhosis, high audit scores, confidence and motivation to discontinue alcohol use, and liver disease quality of life, the 3 and 6 month effect of SAT versus usual care on reducing alcohol use remain significant. With respect to other measures, there were improvements in depression, anxiety, and quality of life at 6 months, but not significantly different by groups. By 6 months, 2 individuals, 1 in each treatment groups, developed new cirrhosis. 2 had new or worsening decompensation. The combined outcome of death or hospitalization occurred in 18 individuals at 3 months and 14 at 6 months. Of the 7 deaths overall, 2 were liver-related. The odds of death or hospitalization did not significantly differ between SAT and control groups. In conclusion, hepatology-based SAT was more effective than usual care in reducing alcohol use at 6 months in patients with chronic liver disease. There were no short-term significant impact on hospitalization or death. Considering the challenges faced by this population, integrated alcohol treatment, including motivational interviewing with addiction services, is a valuable strategy reducing alcohol use in hepatology setting. I'd like to thank our multidisciplinary team of investigators, mentees, research staff, and our funding agency and IAAA, and importantly, our patients for their contribution to this study. Thank you.
We have a couple minutes for questions. Oh.
Hi.
Hi.
Great study. Nitsan Roth from Northwell Health. A question I have for you is, what was the AUD pharmacotherapy use like in each of your treatment arms? Because I guess one of the questions I have is, was this really a benefit of the stepped-up model that you're describing, or is it just that patients who were in your intervention arm tended to, because of their visits with addiction psychiatry and addiction medicine, have more access to medication, for example, than usual care in many of our GI and hepatology practices?
Thank you so much for that question. Very important. With respect to type of medication used, majority of the patients actually received naltrexone. That is pretty much more or less the common medication used in the addiction services settings. I think within the context of the decompensated liver disease, acamprosate was also used.
And what were the rates of use in your treatment arm, in intervention versus usual care?
That's a really good question. I wanted to just maybe preface that with respect to the services or systems that we are dealing with here, we left because of the issue of ensuring that this was sort of by the discretion of the addiction services, the use of the pharmacotherapy on by their choice. And the differences in use was not significantly different, somewhere around 50 to 60%.
Thank you.
Thank you.
Very excellent talk. This is Yihui from Cedars-Sinai. My questions are in terms of the feasibility of getting that many psychotherapists to help with this many motivation interviewing or even step-up treatment. Second is attrition rate. How do we make sure that all these people keep in this trial?
Thank you for that question. So each of the health system had access to one psychologist. So that was used within the healthcare system. And the addiction services were really pretty much integrated within the healthcare system, this being the VA and also the safety net. And then your second question was about? Attrition rate. Attrition rate. Yeah. Okay. Thank you for that. So we had about 12 patients lost to follow-up. As you saw, the patients in this population were extremely ill, with 7 deaths in a very short period of time. It is pretty reflective of that. So loss of those individuals is very minimal, and there was no differences between the two groups with respect to attrition.
Thank you.
Thank you.
Great talk. We are 180 Cleveland Clinic. Question about phosphatidylethanol ethanol levels, baseline or 6 months. This would have been a great, maybe you have that data and you're just hiding it, but it would have been, but I think much more impactful regarding validating sobriety.
Yes. Thank you so much. So at the time of the implementation of the study, this was not particularly considered sort of standard of care. However, for patients who had reported abstinence, we had confirmed the abstinence with use of either PET testing or ETG. Thank you. Yes.
Good morning. Thanks for your talk. Melanie Hunt, Montefiore Einstein in New York. I have a question about the care delivered to the patients who are non-English speaking. I believe you included Spanish and Chinese.
Yes.
So wondering how this care was delivered, if it was through an interpreter or language concordant providers, and if you looked at how this changed the results at all.
I really appreciate that question. Very, very important. It was actually delivered through the use of an interpreter. And we did very much carefully look at the intervention versus the control group, and we didn't see much of a difference with regards to language, proportion of individuals without English language fluency as far as their responses to treatment was concerned. Thank you. Great.
I'd like to welcome Dr. Prashant Pandya at Alpha Health Associates, who's going to give a talk about liver disease activity measured with quantitative MRI is associated with the major liver and cardiovascular outcomes, a prospective cohort study.
Thank you, Dr. Su and Dr. Zhu. I want to thank the organizers for allowing me to present our study on behalf of my collaborators. All right. I have, and these are my disclosures. And in this audience, I don't have to tell you that MASLD is a huge public health concern, not only in the United States, but globally. In a recent analysis, it was estimated that the current prevalence of MASLD is approximately 95 million in this country, and is projected to grow to over 120 million by 2050. The accompanying progression of disease is also projected to double liver-related complications, including hepatocellular carcinoma and liver transplantation. Therefore, developing diagnostic strategies that can help identify these patients is incredibly important. The current clinical guidelines focus on the identification of significant fibrosis, which is strongly linked to development of advanced liver disease and associated complications. However, recent epidemiologic studies demonstrate that the presence of MASH without fibrosis is significantly predictor of poor outcome. In the study on the left, by Dr. Simon and colleagues, utilizing a nationwide Swedish cohort, they examined the mortality outcomes across histologically diagnosed NAFLD throughout its spectrum, of over 10,000 patients with biopsy-confirmed disease and that were matched to nearly 50,000 population controls. They demonstrated that the mortality is significantly increased even in those patients with simple steatosis and progressively worsens with disease progression. Multiple studies have confirmed early observations by Anguillo et al. That cardiovascular disease is the leading etiology driving mortality in MASLD. Hence, a non-invasive test with the ability to identify not only the liver-related outcomes, but also cardiovascular risk, it can be highly beneficial now that therapies for MASLD are available. One non-invasive option with clinical utility, which has been recognized in clinical guidelines, is quantitative MRI. Quantitative multiparametric MRI techniques allow magnetic resonance imaging to characterize liver fat using proton density fat fraction, liver iron concentration utilizing T2 star mapping, and liver disease activity and severity, primarily fibrosis and inflammation, using iron-corrected T1. In this study, we focused on liver fat content and corrected T1. The PDFF is a precise measure of liver fat concentration and correlates well with histologically graded steatosis. Liver fat content derived as PDFF has been well established in MASLD, with a threshold of 5% used to diagnose MASLD and 10% often used as a marker of MASH, especially in identification of subjects entering clinical trials. CT1 is a composite measure of disease activity that in biopsy-paired studies identifies early MASH at a threshold of 800 milliseconds and is a strong indicator of at-risk MASH at 875 milliseconds. In a small cross-sectional study, the baseline CT1 threshold appeared to predict liver-related outcomes in patients with chronic liver disease. Our aim was to investigate the prognostic value of MRI-derived non-invasive biomarkers of liver disease activity and liver fat in assessing the risk of experiencing major liver and cardiovascular events at the population level, as well as in individuals with MASLD. We analyzed data from the UK Biobank imaging sub-study from subjects with available CT1 and liver fat measures. We explored the association between the baseline measures and subsequent development of liver-related events, cardiovascular outcomes, and liver hospitalizations, as well as all-cause mortality. The imaging arm of the UK Biobank is aiming to enroll approximately 100,000 patients. At the current time, approximately 90,000 patients have been imaged, but with our access application, we had access to only 45,000 of these patients. On the average, 4 years since the first scan, we saw the following incidence of liver and cardiovascular events in line with clinical expectations. Cardiovascular events far outweighed incidence of liver-related events or hospitalizations. Overall, the incident rate per 1,000 patient years were 0.4 for liver events, 2.5 for liver hospitalization, and 3.2 for all-cause mortality. Applying Cox proportional models adjusted for age, sex, and BMI, we explored the association with commonly commonly used common major adverse events. The incidence of major adverse cardiac events are associated with baseline CT1, but liver fat concentration was not able to identify this association in a statistically significant manner. Similarly, CT1 predicted all-cause mortality, while liver fat content did not reach statistical significance. For liver-related hospitalization, which included ICD-10 codes that define chronic liver disease, such as cirrhosis, fatty change in the liver, or other inflammatory liver diseases, both CT1 and liver fat concentration were associated with increased rate of hospitalizations. Regarding liver events, we observed a very strong association increasing CT1 and outcomes. Subjects with CT1 values greater than 875 were 15 times more likely to experience liver-related events. Liver fat content did not discriminate a significant association with liver-related events. In our population, of almost 10,000 subjects that met the criteria for MASLD, a PDFF of more than 5, and at least one metabolic syndrome criteria. In this subpopulation, the rate of both liver and cardiovascular outcomes mirrored the trend of the complete cohort. As you can see, in those patients with MASLD, again, CT1 of more than 875 was a significant predictor of liver-related events, with a hazard ratio of 13.7. Liver fat was significantly associated with liver hospitalization in this subset, but with a considerably lower hazard ratio. In summary, MRI metrics of liver impairment are associated with adverse outcomes in the general population as well in the MASLD subset. Only liver disease activity measured by CT1 is associated with risk of new onset liver events with same pattern of major cardiovascular events and all-cause mortality. We conclude that CT1 is an effective non-invasive test for risk stratification in patients with MASLD. Thank you.
Thank you. This paper is open for questions. All right, so while we're waiting for question, I had a question for you. So did you, congratulations on a wonderful study. I was wondering, did you have data on comparators like FibroScan, FIB4? Because, in our facility, access to MRIs can be difficult and also expensive. And so I just wondered if you might have some comparators.
Thank you for that question. No, in this general population, evaluation with other important parameters was not undertaken. We did not have baseline labs also to help differentiate the cohort further.
Another question I had for you was, we often think that the fat goes away once you get cirrhosis. Were you able to adjust with your imaging, maybe the development of cirrhosis, or, because there may be changes on your MRI that could help you adjust for that?
Yeah, I think it's important to realize that, one of the reasons that liver fat did not meet significance in several of these outcomes measures is that with progressive disease, liver fat decreases significantly. So we are working on trying to identify a composite score between liver fat and CT1 to try to identify that question further.
Well, Owoni again from the Cleveland Clinic. Congratulations on this study. With CT1, just trying to think about it as a worthy biomarker for lean NASH. I don't know if you were able to look in your cohort study at lean NASH population, because we have very limited ability to gauge therapeutic efficacy in that population, with I think a known cardiovascular risk in that population as well. Did that trend well with your study?
That granularity of information was not available for us to discriminate, but that's a great point.
Dr. Pandya, congratulations on this very successful study. My question is, how would you recommend the CT1 for hepatologists and gastroenterologists compared to other MR-based study such as MRE?
It's a very important question. Thank you for your question. At the current time, as we try to move away from biopsy, I don't think there's one single non-invasive test that has delivered the kind of information that we need. And so I think we have to carefully evaluate what population would benefit the most from this intervention.
Thank you.
Thank you, Dr. Pandya. Our next presentation is diagnostic utility of bile IgG4 in differentiating IgG4-associated sclerosing cholangitis from similar hepatobiliary diseases, a multi-center study. This is going to be presented by Fosio Ahmed from the Mayo Clinic in Rochester.
Good morning, everyone. Thank you. So I don't have any relevant financial disclosures to disclose. So a bit of a background. So what is IgG4-related disease? So it's an inappropriate immune response. So it's an autoimmune disorder where IgG4 antibodies, which is part of our normal immune system, is collecting in tissues, which leads to inflammation and fibrosis and eventually organ dysfunction. This is seen in a lot of sites in the body, so it's a multisystemic. Most common sites are the salivary glands, so people can have enlarged glands and nodules, and they can also be seen in the bile ducts in the pancreas. So this will lead to pancreatitis as well as strictures in the bile ducts, and patients can present with jaundice. Treatment is effective if once diagnosed, and it's effective with steroids and B-cell targeted therapies. So when IgG4-related disease is seen in the bile ducts, we call it IgG4 sclerosing cholangitis, and this is it kind of mimics PSC and CCA, which leads to a misdiagnosis. And when it's seen in the pancreas, it's called autoimmune pancreatitis. Also, it can also be mistaken for pancreatic cancer because it can develop nodules, which could be mistaken for that. So the clinical challenge is imaging and clinical overlap between IgG4-SC with PSC and CCA, and also AIP with pancreatic cancer. So currently testing is done to detect the IgG4 levels. However, serum testing alone is not a reliable diagnostic test, just because 70% of patients have it elevated while 30% have it normal. Also, other conditions can have an elevated IgG4 level. So this highlights the need for improved diagnostics and possibly bile-based biomarkers. So why are we looking at the bile IgG4? So we can get direct sampling from the site of disease, potentially higher specificity than serum IgG4, and it's also easy to collect during an ARCP. So our hypothesis was IgG4 measurement in bile may have a higher sensitivity for the diagnosis of IgG4 sclerosing cholangitis compared to cholangiography or serum IgG4. Our aim was to evaluate whether bile IgG4 levels can distinguish IgG4-SC from other hepatobiliary diseases, including PSC and CCA. So our cohort consisted of 10 sites in total, 1 in the US and 9 in Japan. So on the right, it's the representation of the map of Japan, and we highlighted the cities where the institutions were. And on the left, it's the map of the US, and we highlighted in green where all the patients were from in the US, but the darker green is where they were all seen, which is at the Mayo Clinic. So we collected a total of 518 samples from patients who had bile duct strictures who were undergoing ARCP. We totally analyzed 462. We had to exclude 56 samples just because we couldn't use those samples. So IgG4 was measured using the Simon's nephelometric analyzer. We also did collect clinical data at 2 time points, at the time of ERCP, as well as 1-year follow-up. We also did collect their etiology for bile duct for biliary stricture. So our primary endpoint was ability of bile IgG4 to distinguish IgG4-SC from other causes. So in total, we analyzed 462 samples. 58 were patients who have IgG4-SC or AIP, and the rest, 404, were patients who have non-IgG4, and under that is CCA, PSC, CCA with PSC, pancreatic cancer, and metastatic cancer, as well as other conditions like gallbladder cancer or gallstones. Patients with IgG4-SC would tend to be a little bit older, although this is not significant. Most patients with IgG4-SC and AIP were predominantly male, and this was statistically significant. Also, majority of our patients, 47 out of the 58, came from Japan. So here we're showing the bile IgG4 level by diagnosis. So patients with IgG4-SC and AIP had the highest bile IgG4 value overall, but you can see there's a small overlap with conditions like patients who have both CCA and PSC in this cohort. So here, to better understand, we kind of zoomed in at 5 milligram per deciliter. And even at lower levels, bile IgG4 is still a bit higher than most of the other conditions. So here we're plotting serum IgG4 against bile IgG4 levels. The dotted vertical line is the upper limit of normal, which is we considered at 3 upper limit of normal for serum, especially since our cohort was from patients from different institutions as well as different time periods. So everybody had a different reference range for the serum. Here you can see that most IgG4-SC patients fall above the serum threshold. However, for the bile, there's really no clear cutoff point. Also, we use 0.2 as a lower limit of detection here. So anybody less than that, we were undetected. So we had 10 patients that we had to exclude because they were below the lower limit of detection. So this is an RC curve which compares how well serum bile IgG4 can diagnose IgG4-SC and AIP. The red line shows serum alone, and it shows an excellent performance of AUC of 0.93. The black line is bile alone, which is much weaker at 0.65. And when you combine them both, it's pretty similar to serum alone, which is also at 0.93. And also we compare the sensitivity and specificity here as serum is still performing way better than bile IgG4 in diagnosing IgG4-SC and AIP. So our limitations was variability in bile collection techniques, a lack of standardized protocol across institutions, off-label. We use an off-label assay, so we use the serum assay to use it for bile. There's really no actual bile assay that we could have used. Also, a possible prior impact of steroid therapy could have affected the IgG4 levels, and also test ordering bias. Only 50% of our cohorts had serum IgG4 level available, which is pretty high. And those levels were high, so we were just wondering that maybe the clinicians ordered that because they kind of suspected something, while the others didn't have any serum available. So future directions, assess links between the elevated bile IgG4 and other clinical factors such as possible contamination, imaging and pathology findings, or other comorbidities, and maybe chemotherapy use. Explore additional bile-based biomarkers, investigate the impact of bile collection variability, and possibly validate our findings in a larger prospective cohort. In conclusion, bile IgG4 was significantly elevated in IgG4-SC compared to PSC and CCA. There is no high specificity cutoff distinguishing IgG4-SC from CCA. Bile IgG4 does not perform as well as serum IgG4 compared to what we were hoping. We will explore other biomarkers in bile that may distinguish the two diseases. Acknowledgements, just wanted to acknowledge all our collaborators in the US and Japan, and also a special thank you to the patients and the ERCB staff. Pictures, not everybody's pictured there. Our funding resources. Thank you.
Thank you, Dr. Ahmed. I have a question. I guess when I'm trying to distinguish IgG4 related sclerosing cholangitis versus maybe a non-IgG4 related sort of more primary sclerosing cholangitis, we often have a liver biopsy and staining on the tissue. And I just wondered if you could comment on sort of bringing these different results from bile and potentially pathology kind of together, and whether or not, I guess basically how you would use those different outcomes or those pieces of data to help clarify the diagnosis.
Yeah, that's a good question. We did kind of go back and look at the pathology results for some patients that did have a biopsy. I didn't include that here, but I think where our end goal is trying to be less invasive, like since they're already having the RCP, what is something that could easily be done once bile's collected to kind of help distinguish that. But definitely when you combine other factors, it would help diagnose it much better.
Thank you.
Hi, Nitsan Roth from Northwell Health. Congratulations on a great study.
Thank you.
I was wondering, I mean, I noticed your population is really quite enriched in IgG4 disease compared to obviously what is typically more common causes of biliary strictures. I was curious if you could speak to just how you guys manage that in terms of your recruitment and designing the study population.
Yeah, so we kind of really didn't limit. So anybody that had a history of a bile duct stricture that was undergoing ERCP, we did include them in the study. But majority of our patients were also from Japan, and I think when they were looking at the study, they kind of more recruited people that they kind of suspected may have bile IgG4 disease.
So this is not like all comers. This was more of a targeted recruitment.
I would say it's kind of both. Like we didn't kind of specify only, but anybody that we kind of felt like did have a stricture that was undergoing ARCP, we did recruit them.
Thank you.
Thank you.
This is Maruf Hotait from University of Pennsylvania. Great talk. One question I have is whether you looked at whether the samples were collected in a patient with a prior endoscopic sphincterotomy or not, and whether that could have affected sort of the inflammatory milieu in the biliary tree and immunoglobulin levels.
Yeah, thank you. That's a great question. Unfortunately, we did not look at that. That wasn't one of the variables that we collected. We did look at if they had a prior stent in place, but not if they had any sphincterectomy done. But we can look at that. Thank you.
Hi, David Assis from Yale. Great study. Thank you. I have two very quick questions if you have time. One is, I think I may have been confused, but you mentioned some patients had already been on corticosteroids at the time of the measurement. If you just excluded those and you only took those who were pre-steroids, whether there was an improvement in the diagnostic yield, that was one question.
Yeah, thank you for the question. Yeah, we did look at that. We did also look at if they had prior steroid use, if they're currently on it, and the duration. We did also do an RC curve looking at steroid, but we didn't really see much of a difference.
Okay, and the second quick question is, what was the actual means for confirming the diagnosis? Did it include serum, or was it only imaging or histological? Because what was the gold standard for the diagnosis then?
So the diagnosis is we looked at both serum as well as the pathology, like they did have a biopsy done, but we also looked at the clinical notes, if like later on if they did diagnose it or not.
Right there.
Thank you.
I'd like to welcome Dr. Heng Zhou, who's going to present combined effect of obeticoic acid and benzofibrate in patients with primary biliary cholangitis and inadequate response or intolerance to ursodeoxycholic acid. 6 months results from a phase 2 trial.
Hello everyone, my name is Heng Zhou, and on behalf of my co-authors, I'm happy to present our presentation titled Combined Effect of OCA and BEZA in patients with PBC and inadequate response or intolerance to UDCA, 6 months results from a phase 2 trial. Before we begin, I would like to disclose I'm the statistical lead in fixed dose combination program in Intercept Pharmaceuticals. OCA is a potent FXR agonist, which is indicated as a second-line therapy for patients with PBC who have inadequate response or intolerance to UDCA. This medication received accelerated approval in 2016 based on improvements in serum ALP levels in the phase 3 POISE study. BEZA is a pan-PPAR agonist, has improved serum biomarkers of PBC-related liver damage in patients who have inadequate response to UDCA. Currently, this medication is not approved for the treatment of PBC. Study 213 was a randomized, double-blind, active-controlled phase 2 trial. After a screening period of 2 to 8 weeks, patients were randomized evenly to one of 4 treatment arms. The first treatment arm is BEZA 200 mg IR. The second treatment arm is OCA plus BEZA 200 mg IR. In the week 0 to week 4, patients received the OCA 5 mg. Then they titrated up to OCA 10 mg after week 4. The third treatment group is BEZA 400 mg SR. The last one is OCA plus BEZA 400 mg SR with 5 mg from week 0 to week 4. Then patient titrated up to 10 mg after week 4. After the double-blind treatment period, patient enter the double-blind follow-up period. Wait for the last patient to complete the week 12 in double-blind treatment period. Then all patients enter LTSE at the same time. LTSE period is 96 weeks long. All patients transition to planned phase 3 dose, which is OCA 5 mg plus BEZA 400 mg SR. Key study inclusion criteria includes a diagnosis of PBC, at least one of the following biochemistry values, including ARP greater equal to 1.5 URN but less than 1.67 URN, or ARP greater than 1.67 URN. The total bilirubin should be within 1 to 2 URN. Patient also need to be at least 18 years old and taking either stable UDCA for at least 12 months before the day 1 or low UDCA for 3 months before day 1. There are a number of key exclusion criteria. For example, a patient should not have the history or presence of other concomitant liver disease and some other histories. All patients should not have the current MERD score greater than 12. We assessed the effect of combination OCA plus beza versus beza alone on the following endpoints. The first one is a percent change from baseline and the normalization rates of serum biomarkers of PBC-related liver damage. The second one is a biochemical remission. It's a measurement of improvement in 5 different biomarkers, including the ARP, GGT, ART, AST, and the total bilirubin. We also assess the global and UK PBC scores. For safety, we summarize the treatment emergent adverse events, coded using Medra dictionary. A range of doses and formulations was explored in patients with PBC who had inadequate response or intolerance to UDCA. Here, we present the data from week 0 to month 6, including the double-blind treatment period and the double-blind follow-up period. The double-blind treatment period included 75 patients. 19 patients were in each group, except for the OCA plus beza 400 mg SR, which only had 18 subjects. The mean age in this overall population is around 55 years old, with over 90% of patients are females. Notably, the baseline ARP in OCA plus beza 400 SR group is higher than the other 3 treatment groups. The mean ARP in this cohort, in this treatment group, is 344. The total bilirubin, total cholesterol, LDL-C, HDL-C are generally balanced across different treatment groups. Most patients receive the UDCA before they enter the study. Here, we show the results for percent change from baseline in ARP and the ARP normalization rate through month 6 across all treatment groups. At month 6, OCA plus beza 400 SR group demonstrated a 65.3% reduction in ARP, which was normally significant compared with beza alone, 400 mg, with a p-value less than 0.05. OCA plus beza 400 SR group also achieved 61.1% normalization rate, which is better than 3 other treatment groups. At month 6, compared with the other treatment groups, OCA plus beza 400 SR also demonstrated the greatest percent reduction in total bilirubin and the GGT. More specifically, there was a 27.6% reduction in total bilirubin with the OCA plus beza 400 SR, and 83.3% of patients in this group achieved the total bilirubin less than or equal to 0.6 times the URN. OCA plus beza 400 SR group also demonstrated a 81.6% reduction in GGT at month 6, which was better than 3 other treatment groups. 72.2% of patients in this group achieved GGT normalization. At month 6, patients in the ORCA plus Beza 400 SR group also had the greatest biochemical remission rate. The biochemical remission was defined as the normalization of ALP or greater equal to 40% reduction in ALP, and GGT, ALT, AST less equal to 1 URN, and total bilirubin less equal to 0.6 URN. ORCA plus Beza 400 SR group normalizing biochemical remission rate is better than all 3 other treatment groups. At month 6, compared with the other treatment groups, ORCA plus Beza 400 SR also demonstrated the greatest reduction in global and UK PBC scores. The ORCA plus Beza 400 SR group reduced the global score by 0.7 at month 6. Similarly, it reduced 1.1 point for UK PBC at month 6. Here, we show the incidence of treatment-emergent adverse events in the first 6 months. TEAEs were generally balanced across all treatment groups. One patient in the Beza 400 IR group, 200 IR group had a serious AE of hypertension. 2 patients in the ORCA plus Beza SR group had serious TEAEs, leading to study drug discontinuation. One of them is breast cancer, and another one is pruritus. In addition, one patient in the same group discontinued due to abnormal hepatic function. The rate of new events of pruritus with the ORCA plus Beza 400 SR group was 2 over 18 subjects. That's 11.1%, which is considered fairly low. In conclusion, these results suggest that ORCA plus Beza is generally well tolerated and has a therapeutic potential to normalize multiple serum biomarkers associated with improved transplant-free and decompensation-free survival. Low rates of pruritus were observed in the ORCA plus Beza 400 SR group, which were substantially lower than those with ORCA in the phase 3 POISE study. The data support phase 3 development of SR formulation of Beza with low doses of ORCA. Here are the affiliations for authors on this presentation. This study was funded by Intercept Pharmaceutical, which is a wholly owned subsidiary of Alpha Sigma SPA. This study was previously presented in a number of conferences, including EASL 2024 and some others. We wish to express our sincere gratitude to all the patients who participated in this study. Thank you very much, and I'm happy to take any questions.
This study is open for questions. I had a question. Beza is not available in the United States. What is your opinion about alternative like fenofibrate?
This is not. Sorry, could you repeat? This is not available in the United States.
No, I do not believe it is. Beza, yeah, bezafibrate. Is that how you say it?
Yeah, Beza is not approved in the United States, and the ORCA is. So we want to test the combination of the Beza effect with the ORCA. If that's successful, we are going to launch the phase 3 trial to test the combo therapy against both OCA and Beza.
Yes, I was just wondering if you had any insight about, many of us off-label, because that's what we have available, consider other fibrates. But another question is, there was still more side effects with the higher doses and the combination, just for the greater liver alphos improvement. And one wonders, what is the threshold? How I think now the idea is you should normalize, but it is associated with increased side effects.
Yeah, so that's why we try to launch the SR formulation. Sustained release is expected to have the better safety profile compared to IR release. We have another study, which is study 214, test the OCA plus Beza IR against the OCA and Beza. So compare the safety profile, the SR formulation is better than IR. And we try to limit the OCA dose to either 5 to at least below 10 milligram. So we consider the risk and try to protect the safety of the patients.
All right. Well, if there are no more questions, this ends our session. Thank you all for attending.
Thank you.